Welcome to the Association of Black Cardiologists webinar, Pulling at the Heart, Faces of COVID-19 Survival and Ongoing Disparities in Diverse Populations. Thank you for joining us for this follow-up webinar to our previous webinar, At the Heart of the Matter, Unmasking the Invisibility of COVID-19 in Diverse Populations. We are especially grateful to those of you who took the time to send notes expressing your appreciation and encouragement after our last webinar. Today, we are humbled by the sacrifice and courage of the COVID-19 survivors and family members who have joined us today to tell us their stories. We are certain that many of you will hear parts of your stories mirrored in theirs. Thank you, Mr. Palmer, Mr. Augusto, and Dr. Sherry for being here with us today. These are heartbreaking times, and for many of us, including myself, who have been personally touched by loved ones with COVID. Please hang in there. I am blessed to have my mother be alive today after being diagnosed, decompensating, and hospitalized in New York City with COVID, which is once again, unfortunately, ground zero. A big shout out to all healthcare workers in the broadest sense, providers, grocery store workers, cleaners, and others. Indeed, I am additionally also familiar with not being able to travel or attend the funeral of a family member because only 4 people are allowed in funeral homes and 1 in the cemetery. Stress, anxiety, and no paychecks are a reality and not in an academic sense. So please know that your ABC family keeps you in our prayers. Thank you to our speakers, Dr. Peter Chin Hong, Narissa Haynes, Peter Alexander, David Williams, who have graciously put in extra time despite frontline busy clinical responsibilities to present this webinar. I will introduce each speaker prior to their respective segments. I also want to thank our CEO, Ms. Cassandra McCullough, our board chair, Dr. Elizabeth Ofili, and the ABC staff, Mr. Alan Merritt, Ms. Rachel Williams, for helping to make this webinar possible. Also, I want to acknowledge Dr. Malcolm Taylor, Dr. Marwa Abdullah, Mr. Jonathan Butler for their contributions. Again, the goal of this program is simple, and is to provide you with clear, credible information about COVID-19, taking into consideration vulnerable groups, especially people of color, buoyed in the faces of survival. This is consistent with the ABC mission, saving the hearts and minds of a diverse America by promoting the prevention and treatment of cardiovascular disease, including stroke, in Blacks and other minorities, and to achieve health equity for all through elimination of disparities. On April 8, 2020, our last webinar sounded the alarm, and here we continue. Next slide. COVID-19, adversity, and race ethnicity. Certainly, since April 8th, we have all been privy to multiple news media, multiple webinars, including papers about opinions related to race, ethnicity, and Blacks in particular, and the COVID-19 pandemic. Next slide. Next slide. However, data are not available for approximately 20% of deaths. Most states are reporting death information by race ethnicity at this point related to COVID-19. Next slide. Indeed, as we had presented back on April 8th, the death rates per 100,000 of the population based on race ethnicity continues to be especially high for Blacks living in this country, 43 out of every 100,000 Blacks in this country, and outpaces other racial and ethnic groups to the tune of 2.2 to 2.6 fold. And these are aggregated national data. Next slide. Next slide. In New York City, which as you've heard, has been essentially ground zero for COVID, among hospitalized and non-hospitalized, persons by race ethnicity. One can note that Blacks and Hispanics outpace whites and Asians in New York City in particular, where Kings County and Queens County have tended to have the highest cases of COVID until a couple of days ago when they were exceeded by Navajo County. Indeed, for Blacks who are non-hospitalized and hospitalized, they have 20% higher prevalence of COVID. Next slide. Certainly, in another place for disparities is in the Navajo Nation. Navajo Nation consists of about 300,000 citizens. Approximately 174,000 of the citizens reside on reservations. The location, Arizona, New Mexico, Utah, is about the size of West Virginia. The reservation homes have 40% have no running water, 30% no electricity, and the life expectancy is 73 years, and much lower than the life expectancy than many of the other racial and ethnic groups in this country. These slides on Navajo Nation are the courtesy of Dr. Mia Lozado. Next slide. These are data from the Office of the President of the Navajo Nation this week. There are approximately almost 4,100 positive cases and 142 deaths. It's important to note that 14% of the citizens have been tested, which is a big deal, versus 3% of the overall US population, which may in part have to do with geographical localization and leadership. The Johns Hopkins data from yesterday indicated that the infection rate per 100,000 residents, as you heard, has now outpaced the infection rates or cases, diagnosed cases in New York. In New Mexico, 6.24% of the population is comprised of folks in 6.4% of the population is AI or AN, but 59% of the population are COVID positive cases. Next slide. And what are the reasons for these differences? Lack of running water, food desert, shelter in places of privilege. You'll hear more about this later again. Historical trauma leading to mistrust of the federal government, lower socioeconomic status, chronic illnesses. Per Dr. Lozado, my patients continue to ask me to share their strengths rather than solely the image of suffering and disparities that are shown in the news. That is not who we are. The stories of resilience, tremendous artistry and talent, interminable family bonds by an extensive clanship system, beautiful culture and ceremonies, thousands of native Navajo speakers. Next slide. So in the next part of this opening presentation, I want to walk through 5 myths related to race, ethnicity, and health with a COVID focus. Myth number 5, Black race is not a predictor of COVID-19 complications because it is all about socioeconomic status and poverty. I want to remind the audience that although strong data exist that lower socioeconomic status is associated with poorer health outcomes, that Blacks in particular have diminishing returns on higher socioeconomic status, particularly as it relates to area level socioeconomic status and education. That is, and there are actually data from Buchholz et al. From Yale, which demonstrate that in post-MI patients, that Blacks who were most socially advantaged, the gaps in the racial disparities between Blacks and whites was highest among those who were most socially disadvantaged, and also among younger Blacks. Racial discrimination limits education, economic, and healthcare access at all SES levels, it's important to note, and desegregation persists regardless of income or education level. Myth number 4. Next slide. Myth number 4, United States minorities have higher levels of inflammation, and thus higher complication rates are due to biology. So data, in part of my research life, I did a fair amount of work on inflammation and cardiovascular disease risk. And some of the data that I'm going to refer to now actually comes out of my research work. So compared to whites, Blacks have higher levels of high sensitivity C-reactive protein, a generalized blood biomarker of inflammation. Markers of inflammation, such as C-reactive protein, are largely influenced, though, by factors such as obesity and social determinants of health, such as the built environment. More chronic disease, which Blacks also have more chronic disease, which are in part dictated by social factors. Next myth. Myth 3. Complications from COVID-19 in racial and ethnic minority groups are primarily due to genetics. Again, I want to remind the audience here that genetics reflects about 20 to 30% of cardiovascular disease. And in all diseases, it reflects 10%. And the rest of our life or health and wellness is related to social determinants of health, whether it relates to social and economic factors, 40%, health behaviors, 30%, clinical care, 10%, and the physical environment, 10%. Next slide. Myth number 2. Excess complications from COVID-19 in racial and ethnic minority groups are limited to persons living in the United States. And this is a question that gets at, sort of ethnicity and the African American and the African diaspora. So certainly we have data from the UK that shows that in Blacks, as well as in Asians increasingly, that the COVID death rate is higher than their population, their prevalence in the population for Blacks. Something happened with the slide. Please move backwards. Yeah. Certainly that the death rate for Blacks is twice that of their prevalence in the population, whereas for whites, it's actually lower than their prevalence in the population. And certainly for UK ICU data, minorities comprise 33% of critical ICU patients, but represent only 13% of the population. Next slide. And the final myth, which I've called a potential myth number 1, is that complications from COVID-19 infection differentially spares younger African Americans and Hispanic or Latinx persons. I would say that the data are still pending by age, but we've also all been privy to news outlets reporting stories about younger African Americans and younger Hispanic or Latinx individuals dying from COVID at higher rates than their counterparts at similar ages. These data are likely confounded somewhat, certainly in the Hispanic population, where there's a large Hispanic population in California, for example. The Hispanic population tends to be younger. However, what I really want to say is that life expectancy, particularly for Blacks, is usually about 5 to 10 years lower based on sex or gender compared to other racial and ethnic groups, which makes me wonder whether or not these stats will indeed hold out. Next slide. So we're about 3 months into this pandemic at this point. What can we learn from this pandemic about cardiovascular disease in particular? And so I sought to put in these slides on meteorologic disasters, COVID-19, and race ethnicities, lessons on ongoing cardiovascular disparities and risk. Following Hurricane Katrina, in the red bar to the left, there was a rise in fourfold increase in myocardial infarction admitted to Tulane Hospital. Pre-Hurricane Katrina, that rate was 0.5%. The higher risk of myocardial infarction was driven in part by behaviors, increased smoking, increased unemployment rate in particular, and non-compliance. Much of the issues related to non-compliance were driven by insurance and all of this driven by stress. Next slide. Unemployment, and we've seen in the United States that this week the unemployment rate is about 16%. Unemployment for African Americans tends to be twice that of the unemployment for whites. So for Blacks, we'd be looking at unemployment rates of about at least 30%, which would be staggering. We know that unemployment is associated with a twofold risk in almost twofold risk in myocardial infarction in the darker slide compared to those who are not employed. And it's also, recent data also should suggest that it's associated with a 1.6 odds higher of atrial fibrillation. Next slide. And then from a psychosocial standpoint, meteorologic disasters are associated with post-traumatic stress trajectories. Post-traumatic stress screen was significantly more likely positive in Blacks post-Katrina. Pre-hurricane mental health of Blacks was worse, which in part contributed to this, and post-hurricane social ties were less. Next slide. So those are things that we need to keep in mind as we move deeper and deeper into this pandemic, as we want to take care of our vulnerable populations. I want to close out with our paper that we had published in circulation at the Heart of the Matter on masking and addressing COVID-19's toll on diverse populations. This came directly out of our last webinar. Next slide. Next slide. This is a graphic from our paper. Go backwards, please. Backwards. This is a graphic from our paper, which I would encourage you all to take a look at. The graphic seeks to highlight the different factors we believe that are related to the health disparities, including discrimination, unemployment, cultural factors, socioeconomic status, access to care, disproportionate burden of comorbidities. I still know we need to do basic science work as it relates to COVID. And then importantly, we highlight solutions, including expanding housing, making dorm rooms available, hotels available, in ensuring that food pantries are able to get federal support and local support, expanding healthcare coverage, supporting internet connection in our communities of color, protecting our healthcare workers by providing paid and quarantine sick leave, partnering with community partners, policy initiatives to address disparities, providing safe, viable transportation, and last but not least, expanding testing and making it easily accessible, as well as pursuing contact tracing. Next slide. So in this webinar, we are going to cover, we've already just covered some of the epidemiology. Dr. Peter Ching Hung is going to cover the virology, testing, and therapeutics. We will have survivors who we are really grateful for, who are going to be present with us today. So we're going to ask the audience to please stay with us throughout the entire webinar. We have some very powerful stories upcoming. And we're going to also cover the psychosocial facets related to COVID-19 as part of the webinar. Next slide. So I want to welcome Mr. Palmer, who is our first survivor, who I will interview during this webinar today. Mr. Palmer, welcome.
Dr. Albert, Mr. Palmer is not online.
So we'll keep going, and maybe you can try to contact him, and we will move on to Peter. So our next speaker will be Peter Ching Hung, who's a professor of medicine and associate dean for the regional campuses at UCSF School of Medicine. He's the director of immunocompromised host infectious diseases program and he's at the University of California, San Francisco. Peter is a go-to expert in infectious diseases. You've probably seen him around every news program in the country at this point, talking about COVID-19. But truly, Peter just really, really cares about this pandemic and how it is affecting, our communities. Welcome, Peter.
Thank you, Dr. Albert. Hello, friends. I'm honored to give this talk on behalf of the Association of Black Cardiologists. For those who remember, being from a remote village in the far south of Trinidad and Tobago makes this topic very personal and full of meaning for me. A shout out to all the Trinis and Caribbean folk out there. First, in the midst of all this, next slide. First, in the midst of all this darkness, I wanted to show some light. This painting of COVID-19 was done for me by one of my UCSF medical students, Nicole Rodriguez, who is from the island of Puerto Rico originally. Gracias, Nicole. Really speaks to, again, finding beauty in some of the darkness that we see all around us. Next slide. Today, you've just heard a lot about epidemiology from Dr. Albert. Today, I'm going to give updates in the areas of virology, diagnosis, and treatment with some specific implications for minority populations. Next slide. Just to review some basic definitions. SARS refers to severe acute respiratory syndrome. Coronavirus is the CoV part, and SARS-CoV-2 is the coronavirus causing the present outbreak. So that's the virus. And the clinical syndrome is COVID-19, which stands for coronavirus disease from SARS-CoV-2. So it's a disease caused by a virus. So let's start with some virology updates. Next slide. Next slide. So one of the issues that's gotten a lot of attention is the issue of whether or not the virus is mutating. A team led by Beth Korber from Los Alamos National Lab in New Mexico found a mutation in COVID-19 that arose in Europe in February and then became very dominant. This is not really an issue for several reasons. It's not a new strain, just a variation on the spikes of the surface of the virus, which is a small change. Virus mutations are, in fact, very normal. One of the biggest RNA viruses out there is SARS-CoV-2, so there's better proofreading and it's more stable, so it's less likely to undergo a radical change, which makes it good for vaccines. So the bottom line is the outsized impact of mortality in minority patients is not really due to virologic mutations or genetics on the East Coast. Let's keep our eyes on the prize. Next slide. Let's talk about some updates in diagnosis now. Next slide. Recall that there are two main flavors of tests looking for the virus, which is direct detection, which is the most common test that you've seen around. This looks for viral RNA. It's the swab and the uncomfortable brain-like biopsy that people have gotten. I've gotten myself, and it's not the most comfortable thing. And then the second group of tests is really around antibody detection. You're really looking for antibody response after you've had the infection. And of course, there are more than 150 different antibody tests out there now, only some of which have been granted expanded emergency use authorization by the FDA. Next slide. So what are some of the tests available now, and what are the updates in testing? Well, the most traditional test that we've had was the RT-PCR, which is what people use in that swab, that infamous swab. There have been variations on the theme like CRISPR-Cas. Probably the newest kid on the block in terms of looking for virus is the antigen testing. It's not as precise or sensitive as the RT-PCR, but like a strep test when you go to the doctor's office or rapid flu test, it is likely going to have testing available to a larger swath of society and basically much more accessible as a first-line test. So more to come on that. I think there's been a lot of development since we last spoke on home test kits. I would say that these include doing your own swabs at home and then sending them back in. The advantage of that is that there's nobody that needs to put on PPE to conduct the test on you. There have been a new FDA approved tests on saliva, which I personally like a lot because it's much less invasive and painful than, and potentially more acceptable than the swab tests. I would say that, and then of course there's a whole wild west of serologic testing. So again, there are two kinds of testing: test for the virus, which is 1 to 5, and then test for the antibodies to the virus, which is a serologic test, which is test 6. But don't hold your breath for minority populations. I think these more convenient tests will cost more. I feel very strongly that these tests should be provided free. And the more that a price tag is attached to them, the lower the chances of these tests being truly accessible to a wide swath of our community. Next slide. Let's talk now about a great demonstration of how population-based screening can be performed in minority population. Diane Havler and others at UCSF worked as Unidos en Salud, a unique partnership between the mission community organizers in the Latino Task Force for COVID-19, UCSF researchers, and the City and County of San Francisco and the San Francisco Department of Public Health. Some of their main objective was really to inform and mobilize a population that's not being reached by current testing and care systems by doing both PCR and antibody testing, and to evaluate a novel community-based test to care program. So essentially what I wanted to do is look at a very heavily Latinx populated census tract in the Mission District of San Francisco, test everyone or as many people as possible, and then determine who are the people who are asymptomatic, who isn't seeking care, and whether or not they were essential workers or not. Next slide. So this slide is really speaking to the fact that it really took a village to undertake this project. Previous slide. Previous slide. Again, it took a lot of people's support, politicians, public health officials, tons of volunteers to go out there and set up these tents, and community organizers. So again, it wasn't like the university going down. It was really a partnership between the community and the university. Next slide. So what are the key findings? The key findings is that in the census tract of about 3,000 residents, 95% of these were Latinx. 150 people actively were found actively infected. And the striking result is on the left side of this graph, which is of the people who were positive in that heavily Latinx census tract, 90% of these were essential workers who couldn't work from home. So these were folks who were still working outside of home. They were furloughed, they were unemployed. They were sort of like out and about trying to get work or being engaged in the workforce and not able to work at home. This is in contrast to the right side of the chart, which shows you sort of like overall statistics in general in San Francisco County with residents and workers, where there are very stark differences. So the bottom line is people who cannot sustain their income while sheltering in place are disproportionately represented in the positive PCR cases for SARS-CoV-2. So when you talk to Dr. Havler, she says that the virus exploits really pre-existing vulnerabilities in our society. And we've seen already that 84% of people coming into San Francisco General Hospital for treatment of COVID-19 are Latinx. And we really need community-based screening to emphasize how high infection risk continues to be for this population. And what do you do with this data? Well, we can respond and maybe start putting resources to work towards more equity in supporting this highly impacted community. Next slide. So one of the big important aspects that Dr. Albert mentioned is when we think about reopening society, you need two things. Apart from the testing that I talked about, you also need contact tracing. And in that square that's highlighted, contact tracing is important, kind of an old-fashioned thing where you kind of go out, you find of the people who are positive, the people around them who have been in contact with these individuals, you then test these individuals, and then you quarantine them from the rest of society. So essentially what you're doing in contact tracing is you prepare to tighten the faucet if the cases spike. Next slide. So what does contact tracing mean for our minority populations? Well, first of all, it's very difficult, and one has to be very sensitive when you have health authorities, volunteers, public health officials going in and asking, first of all, people who are positive, to give information about their contacts. You can imagine how that, giving up that privacy can feel very uncomfortable, particularly if there's mistrust of health authorities. I think there's oftentimes difficulty in translating this lingo, this public health language, particularly if English is not your primary language. This is a quote from someone. She remembers widespread puzzlement about the term contact tracing. People didn't know what a contact meant. Was it someone in your phone book? Was it a sexual contact? So I think really speaking to where people are about these concepts that we take for granted is really important when we think about unfolding these interventions in minority populations. Also, when you get these positive cases, we take it for granted in many communities that it's easy to quarantine. But it's not easy to quarantine for minority populations, as Dr. Albert had pointed out in that summary slide from circulation. If you quarantine, you're going to have lost wages. There's no dedicated space at home. There's data from minority populations showing that many people actually rent out rooms in their home, much more for having their own space so that they can quarantine themselves off from the rest of the family. On the picture on the right of the slide is, one young woman who actually went on a public social media campaign to increase awareness of contact tracing and to advocate for contact tracing sensitively in minority populations. So kudos to her. Next slide. So at the end of the day, why do we want contact tracing and quarantining and all of this? Well, it's particularly more important now in the United States, and I quote Dr. Thomas Frieden, the former commissioner of health in New York City and the former director of CDC. He says, having states and territories all doing competing and uncoordinated experiments in reopening is daring Mother Nature to kill you or someone you love. Mother Nature bats last and she bats 1,000, for those of you who like baseball. Growing up in the Caribbean, I'm more of a cricket fan, but I think people like the baseball analogy. Next slide. So let's talk a little bit about treatment. Next slide. So again, just to add to this last slide that I had in the last webinar, so far we've gotten data around remdesivir. I still think of it as a silver medalist. There's no real gold medalist now. It hasn't really been published yet in the peer-reviewed journal. I know it's been submitted to the New England Journal of Medicine, and we're waiting for review right now. But there was data, as people know, showing a difference in mortality around those who were randomized to get remdesivir, an antiviral drug. There was 8% mortality versus 12% in the placebo. 4 days difference in hospitalization, which could mean a big difference in terms of people's return to work and to income. So it's not really a magic bullet, but it's the best that we have. The other big update in antivirals or drug options for COVID-19 is in the triple cocktail of interferon beta, which is a currently available drug for MS, ribavirin, an old antiviral, and lopinavir, ritonavir, or Kaletra. I give it a bronze medal. It was studied by some Hong Kong colleagues at the Hong Kong University, published in The Lancet about a week ago. It is really a good option, potentially for people who don't and can't get remdesivir, and I'll talk a little bit about the problems in remdesivir rollout that has some impact on our minority populations in a second. But essentially, it's kind of a good option. But the population that they looked at in Hong Kong wasn't a very sick population. It was a more well population. And there was very low mortality in both intervention and placebo arm. But it does show a benefit, again, in duration of viral load, going down to 0, and hospitalization of about 4 days. Another promising, I think, therapeutic option is convalescent plasma. The reason why I like it is you get antibodies from people who've recovered from COVID-19. And it's a gift that keeps on giving. If people know that they have antibodies, they can donate them. And you can infuse these antibodies into our sick patients without like developing a drug from scratch. We need more evidence, and there are trials underway currently. But we've infused some of these plasma units into our sick patients already at UCSF. Again, it's difficult to know what they would have done without the plasma, but they've seemed to have done and tolerated the convalescent plasma very well. There are lots of other drugs of interest, but they're not really top-line drugs in my estimation. They're not antiviral drugs, many of them like hydroxychloroquine. So they're not really exciting to me in terms of being great therapeutic options. In fact, there's some data showing that there's no benefit and more harm as treatment using hydroxychloroquine. Next slide. So again, this is really just showing you multiple sites of action that people are currently investigating, mainly repurposing old drugs rather than developing new drugs, given the timeline that we have. Remdesivir, again, is the most promising drug. It's RNA-dependent RNA polymerase inhibitor. Essentially what it does is stops the virus from making virus children. It stops viral replication. So it's an antivirus drug for a virus, which is kind of exciting if you think about it when you compare it to some of the other thoughts out there like disinfectant. I think some of the issues that I've noticed that may make it difficult for minority populations include the fact that people with low creatinine clearance are excluded from being eligible to get this drug, particularly those who are on dialysis, so that may exclude some of our patients. And the sickest of the sick usually can get it if you are too sick from the trials so far. Next slide. So what has been the issue with remdesivir? Well, it's been a story and frustration and botched delivery. First of all, as people may know, about 2 weeks ago, after the press release from the NIH showing that the interim analysis showed promising results for remdesivir, Gilead donated more than 1 million units to the federal government for redistribution. And there was no transparency about how this was going to be distributed. We were first happy, and then we were sad and frustrated. So when the first 25 sites were announced, at least kind of covertly, there was no announcing of who got it. So we had to crowdsource that information. So one of my pharmacy colleagues actually sent out a survey to all the pharmacists in the country, and people basically reported back who got it. And you can see some of the red dots were people who got it. The blue dots were people who asked for it and didn't get it in the first 25. Next slide. And essentially what happened next is that, again, I'm kind of I didn't expect to be an activist in all this, but I think what this spurred was a lot of us in the community coming forward to demand more transparency from the government in terms of how they were making decisions about who was going to get this valuable antiviral drug and whether or not it was based on need. So I think based on the media attention and a lot of us agitating, Dr. Birx was named as the person who's going to be in charge of it. States were then announced as the recipient of the drug. But again, there's a lot of variation in who's getting which quantity of drug, and a lot of hard decisions at the front lines now as to how we're going to make ethical decisions as, if we have 5 sick patients and we only have 1 course of drug, how we're going to decide. So I think those are decisions that we're making right now. And all of these decisions have impact on our minority populations for many reasons. Next slide. First of all, even being in a trial favors large academic centers with infrastructure. Many of these large academic centers may not be minority-facing hospitals. So it's very difficult at the beginning for minority patients to even have access to investigational drugs. And I'm sure this audience knows that really well. Secondly, the main principal investigators are usually not from underrepresented in medicine populations. Why might this matter? It might matter if you are choosing sites to be part of your sub-studies or be sub-investigators that might have a bearing on that. And then finally, patients and family members often do not advocate for transfer to the investigational drug center. So what we've been seeing on the front line is there's been a lot of advocacy in the community. Say they figure out UCSF has investigational drugs and we have a trial, then people agitate in the community to have their loved ones and family members transferred here so that they can have access to investigational drugs. What I've noticed is that it's very difficult for minority patients in particular to advocate for themselves. And what I've seen happen is that physicians in community hospitals have to then advocate on behalf of their minority patients for them to be transferred, if it is possible at all. Next slide. So I just thought I'd end with a picture of a mango tree from Trinidad instead. Again, so many of these things are frustrating. It's really important for us to stay zen as possible and stay calm and find community in each other, strength and resilience. Next slide. Thanks a lot for your attention.
Thank you, Dr. Chin Hung. I am now going to do our first survivor interview with Mr. Eric Augusto. Welcome, Mr. Augusto.
Hold on. Get my mic. Oh. Hello, can you hear me?
I can.
Okay. Hi, how are you?
Hi, how are you doing? Can we get you on screen if possible?
I don't know what's going on here. I was just on. Give me 1 second here. I'm sorry. That's weird. I was just seeing the other interview on video, so I figured I'd be on.
Stop.
You are on, Mr. Augusto. We do see your video.
You do see me? I can't see myself or anything. So
I can't see the video either.
everyone else sees me though.
All right. Hi, Mr. Augusto. Virtually, I can't see you. But I want to thank you so much for being here with us today to tell us about your survivor story. I should start by having you introduce yourself, who you are, where you live, and so forth.
Sure. So again, my name is Eric Augusto. I am from the Bronx. I am a father of 5, and I also have 2 granddaughters at the age of 43. I have a loving wife, who actually works at Presbyterian Hospital. I'm also a real estate broker with Halstead, Manhattan.
So the volume is a little bit low. I'm not sure that we can hear.
Okay, hold on 1 second. Let me see. Can you hear me clearer?
Yes, so we can, maybe Mr. Augusto just restart.
Oh, so I was saying again, my name is Eric Augusto. I'm from the Bronx. I'm a real estate broker with Halstead Real Estate in Manhattan. I am a father of 5, married, and I also have 2 beautiful granddaughters. And like Dr. Albert said, I am a COVID survivor. So I guess you want to know a little bit about my story, how I.
Yeah, so I'd like you to tell us your COVID story.
So back on March 28th, I entered the emergency room at New York Presbyterian Hospital due to a high fever, severe shortness of breath. Prior to that, I was sick at home. I was trying to, isolate myself from everyone and thinking I could sweat it out, but it just got so severe. When I got to the emergency room, within an hour and a half of being admitted, I was swabbed and tested positive for COVID. Prior to that, I was just doing video conferencing with doctors, and they were telling me to just stay home, isolate myself from everyone, and it would pass. At the point of me going into the ER, I had gone about 7 days without eating. I don't know about the other COVID survivors, but it seems like people I know that had it, lack of appetite is a big thing. So yes, at that point, 7 days without eating, and I was having severe breathing issues. I was begging for oxygen. And I was sleeping a lot too. I was fatigued, I guess, because of lack of oxygen. I want to say within 48 hours of being admitted, my oxygen levels were still low. I had blood in my stool, and I was also coughing up blood. I still had not eaten food, so I probably went about a good 12, 13 days without eating. And then at that point, I was told I was being transferred to ICU, and from there, everything was just one big blur. What I do know is while in ICU, I ended up on dialysis. My kidneys were failing. I had myocarditis, which caused my heart to function as low as 30%. And my lungs were failing me. I wasn't breathing on my own. I was incubated and put on a ventilator for 17 days. I was given a 35% chance. I'm not a spiritual person, but with the love and prayers for my family, my friends, colleagues, everyone, the Zoom prayers they hosted, and 70 people that would join at a time, and the exceptional patient care at Presbyterian Hospital, I beat the odds and I made it.
Thank you, Mr. Augusto. Tell us, would you have considered yourself as someone who had major medical problems, sort of prior to getting COVID? Because you always hear in the news that, you have a lot of, it's people who have chronic health conditions who get sick.
No, I mean, I'm 5'3", so I'm short, but I'm stocky. I hold my weight well. I play competitive softball. I manage a team, so I'm always running. I was boxing. I had taken up boxing for a while now. I work out with kettlebells, or I used to rather, consistently. My only indulgences, I'm a cigar lounge by Yankee Stadium. So, once or twice a week, I would have a stick and, and my scotch, things like that, wine with dinner, things like that. But nothing abusive, nothing, I didn't have any underlying problems. A slight fatty liver from some fried food and, but it was never an issue. I was told by doctors it's not an issue. It was just very slight. I had no asthma, no other conditions or anything like that.
Got it. So being in the hospital being on a ventilator for 17 days, that is a long time.
Yes.
Do you remember anything?
Just drifting and dreaming. I mean, what it did to me was cause ICU delirium. When I awoke, I was confusing things. I couldn't tell what was real or not. My wife helped me through that. I was able to get her on the phone, and I was speaking a lot of gibberish, and she was very supportive. She's like, look, you're going through something that's called ICU delirium. You probably dreamt a lot. There were things that happened, like putting the phone in my ear while the prayers were going on, and subconscious is incredible. Like, it's intriguing to research this stuff because I felt like I was at the prayers and I could hear my wife talking to me in certain aspects. So, but I don't remember much. I didn't know I was incubated and whatnot. It's just
no. And as you aptly said, once you're intubated, the survival rate is about 20%. So we are, very grateful that you're alive and here with us. Could you tell us a little bit about some of the challenges you and your family have faced related to COVID that may not directly be due to you being in the hospital per se?
Well, in general, this virus has turned the world upside down. That's for sure. California, New York, and everyone between. I'm a real estate broker, which makes me an independent contractor or self-employed in the eyes of the New York State. So I work strictly on commission. I've had at least half a dozen clients rather ask me to resell their apartments, or rent their apartments, investment income, investment properties. But due to my commission, I've missed out on opportunities to represent them. I have relationships with them, but they seem to care more about my health than helping me put money in my pocket, and it's tough, when you're self-employed. My wife had to take FMLA leave, to attend to me. I lost 40 pounds. A lot of it was, muscle. So I feel weak. I have a big ulcer on my foot, so it's hurt. And, one income is not enough to support a household of six. There's 6 of us in the apartment. Caused a lot of stress to the family, anxiety, things like that, depression. They were all worried about me, friends, everything. It was rough. It was one hell of a ride.
Yeah. You're pointing out that beyond just the illness, as we've already been hearing in the news and also from yourself, that the economics of this and the financial burden, and also the burden on your family, the stress that the family goes through while you're sick, and even after you've been sick, is pretty tremendous. What recommendations would you give to us about to either us or to the general public with regards to addressing challenges that you're facing or your family are facing?
Sure, sure. The first thing is to be smart. Stay safe, stay informed. I think the more in tune, especially the doctors are, the better the information. I think this is something that everyone's kind of learning as they go. The doctors were honest with me. We watch the media. We have an honest governor who gives just facts. I believe your governor, Gavin Newsom, is very factual as well. So, just staying informed. I want to add something because I know this is this is about minorities and things like that. People from, and it was mentioned before, people from the inner city don't trust doctors. They prefer to stay home and sweat out a cold, a flu, virus, etc. I think the reason COVID numbers are much higher in urban areas, well, one, obvious, we're much more condensed and on top of each other, than people who live in suburban and rural areas. And two, the fact that people in urban areas are much eager to go to doctor's offices, urgent care ER, causes them not to wait too long versus us. We wait too long, and that's the key, timing. I think I waited too long to go in. I know of 4 people in my area who actually died from COVID, and from what my friends were telling me, and they all had the same thing. They waited too long. One young gentleman, 25 years old, actually passed away right in front of his building as the ambulance was pulling up. He was sick for 2 weeks already, and that's the thing. But, just being smart, staying informed, keep continuing the social distancing. I think some of these businesses should not be opening. This is not over, and we're going into the summer. It's going to get worse before it gets better.
Thanks, Mr. Augusto. Any final thoughts that you might have for us?
No, I just think, again, it's just important to stay truthful, keep the public informed, and just making right decisions. This is something so new, and it's devastated all of us. And we're all affected. You're affected, I'm affected, my family's affected. Just stay smart. I hope you all keep doing what you're doing and researching and having these seminars so that, a cure can come out of this. Because I hope that nothing like this ever happens again. This particular virus is very unique. It doesn't discriminate. It doesn't, it holds no prisoners. You could be the healthiest person in the world and die from it. You could be the heaviest and healthiest person in the world and just have flu-like symptoms and be fine. So we all have to take care of each other, take care of ourselves.
And Eric Augusto from the Bronx, New York. Being a New Yorker,
I like you said that.
I feel that your family, you're now part of the ABC family. Thank you for being with us today. And we will make sure that the message gets out. And we're thankful that you're here with us today. And we also pray for your family.
Thank you very much. Thank you all.
The next speaker will be Dr. Kevin Alexander, who is advanced heart failure and transplant cardiologist at Stanford University Cardiovascular Division. He's also a member of the Stanford Amyloidosis Center and a member of the Stanford Cardiovascular Research Institute.
Well, great. I'd like to thank the ABC. I'd like to thank Dr. Albert and the ABC for the opportunity to speak to you today. And also like to thank Mr. Augusto for telling his story. And I think it's a great segue into my talk over the next 10 minutes or so. Next slide, please. So I'm going to discuss an overview of some of the cardiovascular considerations for COVID-19, some background on the pathophysiology, because I think that'll give some insights into some of the cardiovascular complications that we're seeing. Most of the reported literature surrounds adult complications, but there is some emerging data about multisystem inflammatory syndrome in children that I'll also highlight. Next slide, please. So as Dr. Chen-Hong mentioned, the virus that causes COVID-19 is SARS-CoV-2. It enters host cells via the ACE2 receptor and internalizes and leads to viral replication. ACE2 is an important molecule in the homeostasis of the angiotensin pathway. And so there's some thought that there's dysregulation of this pathway during SARS-CoV-2 infection. The internalization of the virus leads to a downregulation of ACE2, and that subsequently decreases the amount of angiotensin 1 through 7 peptide, which is thought to be protective in a number of ways. And it also leads to the increase of angiotensin 2, which is a molecule associated with several deleterious pathways associated with inflammation, vasoconstriction, and thrombosis. From a biological standpoint, we know that regulation of this system has significant variation by race as well. I'm not going to speculate too much about how that interaction may affect cardiovascular complications in COVID-2, but I think it's something to consider when we think about these interactions between biology and social determinants of health. Next slide, please. The other important thing to remember about ACE2 is that it's expressed in a wide variety of tissues. And I think that's part of the reason why there's a wide range of symptoms that people with COVID-19 can have. We heard some of those things from Mr. Augusto. And I'm going to focus particularly on the cardiovascular manifestations. So complications such as myocarditis, heart failure, arrhythmia, and acute coronary syndrome, and vascular complications related to prothrombotic states. Dr. Haynes, whose talk comes after mine, will focus on some of the neurologic complications seen with COVID-19. Next slide, please. So I like to think of COVID-19 infection in terms of stages. And not everyone will go through all these stages, but it kind of gives you an idea of the timeline of when complications can occur. When initially the virus is replicating and leads to symptoms of early infection, so the fever, fatigue, maybe poor appetite. In some people, they'll progress on to what's kind of a later stage manifestations where they develop symptoms of lower respiratory tract infections, so shortness of breath and hypoxia. And that's kind of the inflection point where people are getting sick enough that they may need to be observed in the hospital or ultimately transferred to intensive care units. A subset of those patients will go on to develop more severe end organ complications, some of the ones I showed on the previous slide. And a lot of that pathophysiology is driven by an hyperinflammatory response to the virus. So kind of the body's immune system becomes the big driver of morbidity and mortality. Next slide, please. And so what are some of the drivers of this hyperinflammatory state? It's becoming more apparent that this is an inappropriate immune response to the virus. So we know that lymphopenia or low lymphocyte count is a poor prognosticator for this disease. And lymphocytes are kind of regulators or modulate immune response to various pathogens. And so if that signal is reduced, that can lead to kind of an uncoordinated or robust immune response of neutrophils and other pro-inflammatory immune cells. And that can lead to a lot of end organ damage, such to the heart or kidneys or other organs, some of the complications that Mr. Augusto had mentioned to us. Next slide, please. In terms of cardiovascular complications, some of the earliest markers of injury that we can see are elevations in troponin and NT-proBNP. These are pretty commonly used markers of heart injury. From a coagulation standpoint, we can see evidence of increased platelet activation. Increased D-dimer is also kind of a more signs of a hypercoagulable state. And elevations in ESR, CRP, and interleukin-6 are signs of kind of a global inflammatory state. And so some of the complications that we can see with these cardiovascular injury patterns include heart failure, which is due to suppression of biventricular function due to the milieu of cytokines that are circulating. In some rare cases, or more uncommon cases, you can have direct damage to the heart muscle, which leads to myocarditis. We can see myocardial infarction with as a complication. That's probably a combination of a high inflammatory state, as well as also having a pro-thrombotic milieu. And in terms of thromboembolism, things like pulmonary embolism can occur. And finally, vasculitis is another complication, as direct injury to the smooth muscle vascular walls can be impacted, and so that can lead to vasculitis patterns in a variety of areas. Next slide, please. So what are some considerations for these cardiovascular complications in diverse populations? I think, as you could see from Dr. Alberts and Dr. Chen Hong's talk, we're still at the very early stages of stratifying these outcomes by cardiovascular outcomes by race. There isn't a lot of data that looks at these less common complications of COVID-19 by race. And so certainly more rigorous clinical data will be helpful. But some of the things that I've thought about as relation to these cardiovascular complications, we know that certain minority populations have a higher burden of pre-existing cardiovascular disease, such as hypertension or stroke. And what's does that increase or modulate the risk of developing these specific COVID-related cardiovascular complications? I think that's something that needs to be delved into further. We know that there's differences in inflammatory responses to various pathogens or diseases. For example, African Americans tend to have higher incidences of autoimmune diseases, which are a family of diseases characterized by dysregulation of the immune system. And so I think that that's one area to look into in terms of the interaction with biology in response to this virus. And then finally, and I'm sure we'll hear more in the subsequent talks, are how do access to care and the resources available impact the management of these complications. So as I showed on the previous slide, there's some early markers of myocardial injury that can precede these manifestations, such as heart failure, myocarditis. And so a lot of, to make the big impact on managing this is to have a high clinical suspicion, identify those patterns of injury early so that supportive measures can be implemented, such as inotropic therapy, mechanical ventilation, and other things to support the cardiovascular system. And so in resource poorer places, that might be challenging in order to implement those diagnostic protocols, but also to have the resources to provide this intensive care. And so any kind of racial or socioeconomic disparities in this regard could impact outcomes of these cardiovascular complications. Next slide, please. So I just wanted to touch on this because it's been something that's emerged in the last few weeks, is this observation of a rare complication in children infected with COVID-19. Overall, children seem to be less impacted or have less severe COVID symptoms than adults, but this syndrome, pediatric multisystem inflammatory syndrome, has been recently reported in the New York Times. There's a Lancet article on it as well, describing this as a potential complication. It's a Kawasaki's disease-like vasculitis, so it affects medium vessel arteries, such as the coronary arteries, and it can lead to a variety of systemic manifestations, such as myocarditis, shock, and other end organ failure. It's thought, in terms of mechanism, that this is potentially a post-infectious inflammatory response, because the symptoms tend to lag behind the infection with COVID-19 by a week or two. In comparison to kind of the historical Kawasaki's disease, the children with this multisystem inflammatory syndrome tend to be older, so teenagers, and they tend to have more severe symptoms compared to the classical Kawasaki's disease. And on the right is a study from a single center in Italy, looking at their incidence of Kawasaki's-like cases over the last 5 years. And you can see they have kind of a handful of cases every year, and they had a spike of these Kawasaki-like cases in the first 2 quarters of 2020, kind of overlapping with their outbreak of COVID-19. In about a 30-fold increase over kind of the baseline incidence of Kawasaki's disease at that hospital. And most of those cases were characterized as severe, again, highlighting that this is a more fulminant presentation than classic Kawasaki's disease. There was a study that came out in Circulation recently that looked at using steroids and intravenous immunoglobulin as means to treat this, and seemed to be effective, albeit there was no control group with that. But I think having awareness that this is a potential complication is important, so that we can implement some of these interventions and hopefully avoid some of the long-term complications that we know we can see with myocarditis or vasculitis syndromes. Next slide, please. So some of the outstanding issues I think to consider with cardiovascular disease and COVID-19, I've alluded to it. I think we need to better understand some of the biologic and socioeconomic factors that influence the risk of developing some of these more severe complications. And with that understanding, we also need to identify targeted treatments to either prevent or reduce the burden of morbidity and mortality from these cardiovascular complications. And I think, like with Mr. Augusto's story, who fortunately was a survivor of these severe complications, we need to better understand how we can minimize any kind of long-term sequelae from these complications in COVID survivors. And so registry type studies and longitudinal follow-up, I think, will be key for that. So with that, I thank you for your attention and look forward to the Q&A.
Thank you, Dr. Alexander. And certainly, I believe that Mr. Augusto's case your presentation nicely highlights probably what happened at a biological level in Mr. Augusto's case. Our next speaker is going to be Narissa Hayes. Dr. Narissa Hayes is the fellow's representative to the board of directors for the Association of Black Cardiologists. She's a cardiology fellow at the University of Pennsylvania School of Medicine. And she will be talking about rare complications of COVID as well as CNS complications.
Thank you, Dr. Albert, for that introduction. If we can go to the next slide. So I will be providing updates on the clinical manifestations of COVID-19 with a focus on the central and peripheral nervous system. So if we can go back one slide, please. Over time, we have discovered that COVID-19 impacts almost every organ system in the body by binding to ACE2 receptors, which are present in many organ systems, like Dr. Alexander mentioned. So we know it impacts the lungs, leading to very low oxygen levels. It can cause liver injury, kidney injury, and many patients end up on dialysis. It can affect the intestines or the gut. About 20% of patients with COVID-19 have GI symptoms or diarrhea specifically. Dr. Alexander outlined the impact on the heart. We'll discuss a little bit how COVID-19 can affect your sense of smell. It can also cause inflammation of the eyes, leading to a conjunctivitis. And then lastly, it can affect the brain. And we'll get into that in a little bit more detail. Next slide. Before we start talking about the central nervous system and the peripheral nervous system effects of COVID-19, I just wanted to highlight a dermatologic manifestation of COVID-19 that's gotten some press in the media. Called COVID toes. It's characterized by painful red or purple lesions on the toes, and it's similar to a condition called chilblains, which are associated with exposure to cold temperatures or damp temperatures. The pathophysiology is thought to be vasoconstriction or inflammation of these small vessels in the feet. It's usually seen in younger people who have a more mild course of COVID-19, and it typically resolves within a few weeks. Next slide. So moving on to the neurologic complications of COVID-19. Next slide. The most common complication that has been written about thus far is stroke. The New England Journal of Medicine published a small case series of strokes in young adults, and I'll just highlight one of those cases. A 33-year-old woman who presented with common COVID-19 symptoms such as cough, headache, and chills. She developed dysarthria, which is a change in her speech. She had difficulty speaking. She also developed numbness and weakness in her left arm and leg. The CT, or the CAT scan of her head, is shown here on the right. And what you can see is that she had a quite large right middle cerebral artery infarct or stroke. Next slide, please. So as discussed earlier, what we have found with COVID-19 is that due to cytokines and significant inflammation, it causes a coagulopathy, or it alters the way blood clots. And we've seen a lot of clotting in patients who have COVID-19. So what has been written in the literature is that patients who have COVID-19 typically have elevated fibrinogen levels as well as D-dimer. Their inflammation markers are elevated, so significant inflammation. Unlike DIC, their PTT and PT are only mildly prolonged, and platelets are not significantly decreased. There are a few case reports of lupus anticoagulant being positive, or antiphospholipid syndrome as well, with severe COVID-19 cases. But importantly, what we do know is that race and ethnicity also affect thrombotic risk. African Americans have a 30 to 60% higher incidence of thromboembolism or clots compared to European Americans. African Americans also have a 2 to 3 times increased incidence compared to Asian Americans. So they're more likely to have clots, such as clots in the legs or in the lung. And this picture on the right is just a microscopic image of a blood clot. Next slide, please. So given that COVID-19 increases inflammation and increases the rate of strokes that we're seeing now, it's very important to be able to identify the symptoms of stroke. And fittingly, May is Stroke Awareness Month. So a good acronym to remember the manifestations or the symptoms of stroke is B-FAST. B stands for balance. So oftentimes people who have a stroke will have imbalance or they fall over easily because of balance issues. E is for eyes. So one symptom of stroke can be a change in vision. F is for face. So a lot of times patients with stroke will develop a facial droop or asymmetry in the face. A is for arms. So it's not uncommon for patients who have stroke to develop weakness in a limb, arm or leg. S is for speech. So if someone's speech becomes slurred or if they're having word finding difficulties, that can also be consistent with a stroke. And the T stands for time. Just like a heart attack, time is critical, and patients need to get to the emergency room and to the hospital as soon as possible for treatment. Stroke is also more common among African Americans, and this is thought to be due to a higher prevalence of high blood pressure or hypertension. Next slide, please. So COVID-19 has direct and indirect impacts on the brain. And I just want to highlight some of the unintended consequences of COVID-19. So due to fear of being infected with COVID-19, many people who have stroke symptoms, the same symptoms that we just outlined on the other slide, stay home and they ignore those symptoms. So there have been publications describing decreased admission rates for stroke and people just staying home and ignoring those symptoms. Another thing that has been found is due to the hypercoagulable state of COVID-19 and increased incidence of clotting, more and more patients are being treated with anticoagulation, such as heparin, while they're in the hospital, and this is leading to higher rates of hemorrhage or bleeding in the brain. And the last point is that there are increased rates of anoxic brain injury. And anoxic brain injury is when your brain doesn't get enough oxygen. And we know patients with COVID-19 have very low oxygen levels. They're very hypoxic for extended periods of time, which can lead to brain damage. Next slide, please. I'm just going to highlight a few rare complications of COVID-19. And one of those is the acute necrotizing hemorrhagic encephalopathy, or ANE. This has been seen in other viral illnesses as well. It's extremely rare, but there are case reports describing it in COVID-19 as well. One case highlighted a female airline worker in her 50s who developed cough and fever and then altered mental status. So she became acutely confused. She tested positive for COVID-19 and then developed weakness in all 4 of her limbs. The prognosis for acute necrotizing hemorrhagic encephalopathy is very poor, so a very bad prognosis. It is usually preceded by a viral illness, such as COVID-19. And the typical imaging that you see, as you can see here on the left with this MRI, is symmetric brain lesions. And these are thalamic lesions that you see here on the left. Next slide. Another rare complication that has been described in just a few case reports is PRES, or posterior reversible encephalopathy syndrome. This is a systemic inflammatory state, and it leads to endothelial dysfunction of the vessels in the brain. It's commonly associated with very high blood pressures or certain medications, but it has been described with COVID-19 as well, where patients are presenting with a PRES-like syndrome, and they develop vasogenic cerebral edema in the posterior parts of the brain, as you can see here in the MRI on the left. Next slide, please. So anosmia, or loss of smell, has gotten a lot of media attention and is a common symptom for patients or people who test positive for COVID-19. So COVID-19 can get access to the olfactory nerve, which is the first cranial nerve, either through systemic vascular dissemination or by traveling through the bones of the nose and infiltrating the nerve, essentially, that controls your sense of smell. Next slide, please. And similar to anosmia, you can develop ageusia, which is your loss of taste. And very similarly, COVID-19 does not only affect the olfactory nerve, but can also affect the glossopharyngeal nerve, which controls taste. So some people develop loss of smell and loss of taste with COVID-19. Next slide, please. And the last thing I would like to highlight is how COVID-19 can affect the peripheral nervous system as well. And there are case reports of a syndrome called Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome. And again, this is not specific to COVID-19. It's been seen in other viral illnesses, but it has also been described in COVID-19 and is also extremely rare. Guillain-Barré, the hallmark of Guillain-Barré is ascending paralysis, where people will develop weakness in their legs that moves up to their arms, and it can also affect the respiratory muscles. Miller-Fisher is characterized specifically by abnormal muscle coordination, so imbalance, eye muscle paralysis, and absence of tendon reflexes. And again, it's preceded usually by a viral illness. And for example, Guillain-Barré was started to be very common with Zika, and we are also seeing it being associated with COVID-19. Next slide, please. Dr. Albert, I think you're on mute.
Thank you, Dr. Narissa Hayes. Our next speaker will be Dr. Magdala Sherry, who is a survivor. Dr. Sherry is an assistant professor of medicine at Rowan University School of Osteopathic Medicine in Stratford, New Jersey. She was named South Jersey's magazine's top docs in 2018 and 2019. Most recently, she suffered the tragic loss of her father and her mother to COVID-19. Please accept our sincerest, deepest condolences about the loss of your parents. Dr. Sherry, on screen.
Yeah, can you hear me?
Yes, I can hear you, and I also now can see you.
Awesome.
So once again, thank you so much for being with us. I would invite you to share your story with us. I know that your story is it's a very moving and powerful one, and I do want to give it justice. I still have to be cognizant of the time, and I want to advise the audience that we're going to go approximately 15 minutes over. We're going to end the webinar at 1:45 p.m. Eastern Time.
No problem. Thank you guys for having me. To start with my parents' COVID story and myself as well, I do want to start with talking about the narrative of my parents. Both of my parents, Mario and Ketley Sherry, were Haitian immigrants who migrated to the United States in their 20s. basically built the life of the American story. It's important as I talk about how they presented and what it looks like to talk about who they are and what they did. My father was in fact 63 years old. He was the full-time caregiver for my mother, who was diagnosed with Parkinson's disease and had many medical complications. My father would die first on Easter Sunday at 6 o'clock in the morning on April 12th. But just to be clear, he had no pre-existing conditions. He was fit. He had never been hospitalized before, never had to go to the doctor, does not take medications, is not obese, was not a smoker, all the things that are often associated with why Black people are dying more, he didn't have. So if anything, when I was alarmed about the virus and who would be at risk, we were more so concerned about my father bringing it home because he is a preacher. He's an evangelist in the Haitian community, a radio station personality, very well known in the North Jersey community and in the Haitian community at large. My mom was 60 years old. She, like I said, had Parkinson's disease. She would end up dying at home. So if I can give a timeline, I think which would help the narrative. So we all remember when the NBA announced they were going to suspend the NBA, and that was around March 11th, March 12th. I'm using that as an anchor because that is when my father and my family started to take it seriously, to be honest. And most of the community at large, that's when it feel like, oh my gosh, this may be really serious if they're suspending a whole season. So I would last see my father and my parents initially that weekend of March 13th, March 14th, and March 15th. And that Sunday, March 15th, my father did go to church. This is key because in my home church, it's a Haitian-born, Haitian-speaking church in North Jersey. We have had multiple deaths. We are in the double digits of the people who have not only been positive in the hospital and people who have died. So he would go to church. He would go to a couple churches. And I remember distinctly that Sunday saying, "Dad, get home ASAP. I'm really concerned about something happening to you." Come back to South Jersey, which is where I live and I practice, and I would just be monitoring them from home. My father, in fact, did not tell us initially he had symptoms. He would develop symptoms about 7 days after that. So about March 22nd. Didn't share he had symptoms because he didn't want to go to the doctor. He didn't want to go to the hospital. He's uninsured and he didn't trust the system. And he's Creole speaking. So he was concerned that he wouldn't be able to articulate how he felt. The only reason why I even knew he had symptoms by March 25th is because my mom called us on the phone and she's like, "Your father's not going to tell you this, but I don't like how he looks. He's actually been passing out at home." At one point, my mom, who's very weak, had to throw her body on the ground to break my father's fall because she was very scared that he would hit his head. And she said, "Please come check on him." I go home, I bring my full PPE from my house and from work and go home and check on him. He's relatively stable. He's adamant about not going to the hospital. So, I start him on Tylenol. I tell him to make sure he's eating. I provide food for him and my mom, and I have it all lined out for him. I'm like, "You're going to call me every day. You're going to let me FaceTime you. We'll figure out what we have to do to see if we can tolerate treating you at home." Every day, he actually seemed like he was improving. He was back doing to his church activities remotely and virtually, and we thought we were heading in the right direction. On March 29th, I noticed my family had not contacted me and we didn't hear anything. So by Monday, March 30th, I had my sister call because I was seeing patients virtually at my apartment. And I said, "Call and check on our parents. Something doesn't feel right." She called. While I'm seeing patients, she shows me the image of them on FaceTime and she's like, "Dad doesn't look really good. I don't really like it." So I still had patients to see and I also had to teach that afternoon some small group virtually. So I sent my sister first. I sent her with a thermometer, a pulse ox, and I said, "You're gonna call me back with vitals and let me know how Dad's doing." She gets there, she's like, "Dad doesn't look good. His pulse ox is in the 80s, mid to low 80s. So I just jump into a car and I go because I know my father will not go without me. I can't send an ambulance. It has to be me. So I get there. I also check his vitals. Does not look good. He is literally belly breathing and cannot even walk and put on his clothes. It takes him at least 30 minutes to put on his clothes. So my father was adamant. He was afraid about a bill. He's like, "We can't afford a bill. Our family cannot afford this. Your mom's medical care is very expensive. I can't do this." So I had to plead with him. "It's okay. I'll figure it out. If I have to take on the bill, it's okay. Please go." And the next comment he said to me is, "This system doesn't care about us. I'm just a Black person. I'm just an immigrant. They're going to hear my accent and they're not going to care." So I had a choice. I said, where do I take him? And I bring this next point up because when I share where I took him, which I took him to an inner city community hospital, which is part of the larger system of Robert Wood Johnson, I get a lot of pushback from a lot of my community. Well, why didn't you go to the whiter hospitals? And I said to myself, one, I knew someone in the ER at this particular hospital. I also knew most of the staff was Black. I also knew there was a lot of staff that would speak Creole. So if I could pick anywhere that would give my father comfort and that would help me and be my eyes when I couldn't be there, this is where I would want to go. So we go to this hospital and I'm able to get some pull because I knew someone in the ED to allow me to at least stay with him in the ED, act as his translator, try to convey to him that he has to stay. Because he was adamant, if you go back in the car and you drop me off here, I'm telling you now, I'm going to leave AMA. I'm not staying. I don't trust anybody here. So they allowed me to stay so I could translate for him, so I could explain things for him. He had the classic signs on x-ray, classic signs on the CAT scan. And then eventually we were able to convince him. First thing,
Dr. Sherry, it sounds like there were a lot of different barriers that your dad, both individual and systemic, that resulted in him either not going for care and also, not getting the level of care that he deserves. Can you tell me, how he passed away, one, and then two, and how your mom passed away, and your thoughts about and your thoughts about recommendations for COVID-19
definitely
going forward. So we have about 3 to 4 minutes to cover.
Okay, no problem. So just so I can try to put this as concisely as possible. So my father would get admitted on the 30th of March. There was a long wait. There was one hospitalist to COVID patients, which I want to make sure I mention. They ran out of oxygen tanks in the emergency room as well too, and they were quite understaffed. It's important for me to emphasize that I was not getting routine updates. They knew I was a physician. They got 3 security guards and multiple nurses to escort me out. They wanted me escorted before telling me what the plan was, before telling me what my father was treating on, and before even allowing me to speak to the physician. So had no choice. Dad was not doing well. We left him there. I was fortunate that I had an iPhone, so I could leave that and FaceTime him, so I could at least tell him, position your phone, and so I can get an idea of what's happening to you. Many times I wasn't happy with his care, and I spoke to a doctor maybe twice, and I had suggested, hey, could it possibly be that he has a clot? We're doing everything, he's not improving. And they said, oh yeah, well, he's the best one on the floor, so hopefully. He was never intubated, just to be clear. He was on a venti mask, about 15 liters at most. The thing is, my father complained a lot about not being able to get water and not being able to get help to go to the bathroom. So multiple times during his stay, he would take off his mask, go get water, like whether it's a sink, go to the bathroom on his own without oxygen. Despite my plea to say, don't do that, your requirements are too high. But he would say I'd wait for hours and no one would answer the call bell. No one would come see me. There's not enough nurses here. I think this is important to understand how he dies. So the evening before his death, April 11th, it looks like, or around that time or early in the morning, my father goes to the bathroom yet again without his mask. He is not continuously monitored on pulse ox. No one knows he got up. So my father was found on the ground of the bathroom in this hospital without oxygen and basically suffocated for air. He was found in PEA arrest. They tried to do CPR, but they could not resuscitate him. And that is how he ends up dying on Easter Sunday in the morning. Now,
that is awful. That is really awful.
Yes, and what's happening at home in light of this is my mom also has symptoms and I also have symptoms. My mom was so bad that I had asked her, I was like, do you want to go to the hospital? She said no, because she saw how we were struggling to get information about Dad. So she made it clear that she wanted to be home. I was talking to her physician about how to treat her. Eventually, it wiped her out. I think the last patient had just shared that he lost so much weight. My mom had to at least have lost 15 to 20 pounds. Eventually, she decided she wanted to be comfort care. She would not go to the hospital. She said, I'd rather, if I'm going to die with my children at my feet, to be able to die on my own terms and be able to go the way that I want to and die with dignity. So my mom would later die May 1st at home in our care on her terms.
Thank you, Dr. Sherry. We really appreciate you being with us to share your story. And perhaps maybe we can come back again, and if we have enough time in the question and answer. I want to be cognizant to Dr. Williams this time, who has to leave to go to another webinar immediately after this one. So I'm going to proceed to Dr. David Williams, who is the Florence and Laura Norman Professor of Public Health, the chair of the Department of Social and Behavioral Sciences at Harvard School, T.H. Chan School of Public Health. He's a professor of African and African American Studies and of Sociology at Harvard University. He actually developed the Everyday Discrimination Scale that's widely used in research about discrimination in health. And he has been cited as one of the world's most influential scientific minds by Thomas Reuters. Welcome, Dr. Williams, and thank you so much for being with us here today.
Thank you so much, Dr. Albert, and thank you for putting together this really outstanding panel. I've been honored to be a part of it. I'm going to just give you quickly a few highlights of making sense and putting into larger context the patterns we are seeing for African Americans and other populations of color. The next slide gives us a sense of data on Black deaths by location. So the bottom line shows the percentage Black in the particular state or locality. So it starts out with Washington, D.C. 44% of the population there is Black, but 79% of the deaths in Washington, D.C. are Black. And you can see for Michigan with 14%, 43%. And you see that pattern continues in Louisiana, in Wisconsin, in Illinois. The next slide gives us examples of more states: Georgia, Mississippi, Maryland, New York, New Jersey. It is across the board. There are many more states that show that pattern, but you get the picture that almost everywhere in the country, the impact is overwhelmingly, disproportionately negative for African Americans. The next slide puts these disparities of COVID-19 into larger perspective. So just picking one widely used outcome is life expectancy at birth. And I'm showing you data from 1950. Let's go back 1950 to 2015. And you could see there was an 8-year gap in life expectancy in 1950. And the good news is it's a 4-year gap. So we have made progress. At the same time, look at the life expectancy of whites in 1950, 69.1 years. How long did it take for African Americans to have the level of health that whites had in 1950? It's not until 1990, 40 years later, that African Americans equaled the health as measured by life expectancy that whites had in 1950. And if you look at the average rate at which life expectancy has been increasing in the last decade, if we froze the life expectancy of whites, it would take about 30 years to close the about almost 4-year gap in life expectancy that exists today. So my point is, these disparities exist for a broad range of outcomes, and they have existed for a long time. The next slide begins to unpack why do we have these disparities in health. The next slide takes a deeper dive on income. This is the latest data from the US Census Bureau, 2019 report, median household income in the United States in 2018. And median household income for African Americans and Native Americans is $41,000. That means half of households, this is not individual income, but household income, African American have less than $41,000 total household income, and half have more. The next slide puts these data into context in a way you can't go back one. You can't possibly miss the point. I'm standardizing on the household income of whites. And I'm saying for every dollar of household income white households receive, Asian households at $1.23. Asian households heavily made up of immigrants. Asian households have more persons contributing to household income than any other groups. So if we did a per capita measure of income, whites would be the highest. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latino households have 73 cents, Native American and African American households 59 cents. What's striking about the 59 cents figure for Blacks is that it's identical to the Black-white gap in income in 1978. I did not misspeak. You heard me correctly. 1978 was the peak year of the narrowing of the black-white gap in income as a result of the civil rights policies and the anti-poverty policies of the 60s and 70s, and it was reduced to 59 cents. And in 2018, we are still at 59 cents. Now, has it been stable at constant at 59 cents over the years? No, it hasn't. Throughout the decade of the 1980s, it fell from the 59 cents level. Reaganomics was not good for the Black population. And it wasn't until 1994 that it got back up to 59 cents, and it's been a penny up and down since then. The important take-home point is economic inequality by race is much larger than clearly most of my students think, who are really surprised to see data like this. And the next slide makes the point that as bad as the income data look, states the true degree of economic disparity. Because income captures the flow of resources into the household, it doesn't tell us about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth. And the next slide is the latest wealth data for the United States from the Federal Reserve Board. It's a 2017 report for 2016 data. For every dollar of wealth that white households have, Black households have 10 pennies and Latino households have 12 pennies. What does this mean? The next slide talks about what does this low economic status mean? It means that even though we are in the same storm, populations of color are actually in different boats. The next slide out some of the ways we are in different boats, that low income, and I think this was highlighted by Dr. Albert at the beginning, just don't have the opportunity to follow some of the guidelines that are the protective guidelines. And for example, one study in New York City finds that among the essential workers, 60% of the essential workers in New York City are persons of color. The next slide. All of this economic poverty combined with segregation, which I don't have time to elaborate on, and living in disadvantaged neighborhoods leads to higher levels of multiple stresses: economic stresses, psychosocial stresses, racial discrimination, and physical chemical stresses. The next slide gives the example from one study that looks at air pollution and documents that air pollution, if you live in an area of higher levels of air pollution, COVID-19 is more severe. Cases are found in those contexts, and the risk of death is actually higher. So that's another factor about the context that is captured here as well. The next slide. The stress of discrimination and its effects on health, that is an added burden that populations of color face. The next slide gives the example of the everyday discrimination scale that Michelle mentioned. And what's striking about this, it's not the only measure of discrimination, but it's one that captures just the little day-to-day indignities. And just to give you a sense of what we have found for the everyday discrimination scale, the next slide gives you an example of outcomes that have been shown to be linked just to everyday discrimination. And you can see, yes, just keep going. It's a broad range of outcomes, from markers of subclinical disease to markers of preclinical cardiovascular disease, to how people access the healthcare system, to the onset of major chronic conditions, to mental disorders, a broad range of outcomes. Higher levels of everyday discrimination in published peer-reviewed studies are linked to all of the outcomes listed here. The next slide says, what's the consequence of all of these stressors from all of these different sources on persons of color? In the research literature, researchers have used it that African Americans and other persons of color are aging at an accelerated rate. Some have used the term premature aging, others have used the term biological weathering to capture the fact that chronological age, persons of color in the United States have indicators of being older physiologically because of the degree of biological dysregulation they face. And that leads to the onset of chronic disease. The next slide gives an example from data from the CDC, giving you one example of the earlier onset of chronic disease. And just let's look at persons aged 50 to 64. And by age 50 to 64, you see that 61% of African Americans have hypertension compared to 41% of whites. And that pattern exists for a broad range of outcomes. The next slide shows that just for another diabetes as another outcome that fits that pattern. And what does this mean in the context of COVID-19? The next slide draws on one of the largest studies yet published, 12 New York hospitals, almost 6,000 patients, looking at what are the comorbidities found in this group. And you could see hypertension, number 1, obesity, number 2, diabetes, number 3, heart disease, number 4, respiratory disease. So you can see this is among the hospitalized patients. The next slide shows the percentage of patients hospitalized who had none of the comorbidities you just saw, and that's only 6%. And the percentage who had only one of them, just 6%. So 88% of persons hospitalized in this large study of almost 6,000 patients had at least two or more of these comorbidities. And you see the risk factor. And importantly, what I'm emphasizing is the social context of the lives of populations of color are the factors that put them at this pattern of higher risk. Next slide. I'll just mention in passing that individual discrimination in healthcare is important. Next slide. The unequal treatment report from the National Academy of Medicine talked about the importance of this, and we're getting hints in some of the stories that were given today that this seems to be operative in the context of COVID. Next slide. What exactly do we do? What can we do to address these inequities in health? I think Dr. Albert made a number of good suggestions up front of improving access to care and quality of care. The next slide says, if we are going to address these disparities long term though, we need to do what I call build communities of opportunity. We need to think of how we invest from early childhood and reduce childhood poverty and put people to places where they have ladders of opportunity so that we can improve the social determinants of life. We can improve the conditions of their lives so that they can have the opportunity to have good health and be in places that in fact promote good health. My final slide, I want to leave you with the words of Martin Luther King. He said, "It may well be that we will have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and the indifference of the good people. We are in the COVID-19 crisis. We cannot let this crisis go to waste. We need to use this opportunity to advocate for the long-term strategies that will improve the quality of life for persons of color in the United States." Thank you.
Thank you, Dr. Williams. Thank you, Dr. Williams, for a really nice presentation. I know that you had to make certain sacrifices to actually be here with us today, so I really appreciate it. I think given the interest of time, what we will do is that we've actually been collating your questions that have been sent to us by the chat room, and I will announce what we will do with those shortly. But our last survivor did join us, and his name is Mr. Palmer. And I would like to, take 3 to 5 minutes to have Mr. Palmer tell you his story before I close out the webinar.
Thank you, Dr. Albert.
Hi, Mr. Palmer. Welcome from Mississippi.
Yes, ma'am. How are you?
I'm good. I'm good.
Thank you.
As you might realize, we are a little bit pressed for time at this point.
Yes.
So I'm going to try to be concise. Just tell us a few lines about your COVID story.
Well, mine started I'm a dialysis patient, also a heart patient. I do dialysis at home. I noticed during my dialysis treatments, my temperature was running a little high for a few days. From that point, I went, got tested, came back positive. That's how I started with my COVID.
Got it. And you're also a police officer, right, Mr.
Yeah, that's correct.
Palmer?
I'm the police chief of Crystal Springs, Mississippi.
Right, which is a small town of 5,000 people, you told me?
Yes, ma'am, that's correct.
Mississippi, yes. Do you know how you contracted COVID? Any idea?
I do not. With the medical history that I have, when it started, I kind of talked to my HR people and started to quarantine at that time. So I'm not sure how I caught it. I don't know, because I wasn't going anywhere and just quarantining myself at home.
Excellent. Tell me, can you tell me 2 top challenges that you had either related to quarantine at home or just dealing with COVID as you were struggling with it for the weeks that you were?
Well, the largest challenge I had was being away from my family. We had to isolate in the same house. So I had to move my wife from one room to another. And I had to stay in by myself. I couldn't see my grandkids, who's my heart. I couldn't see them. I didn't like the biggest challenge I had is when I tested positive, it was like, you're positive and there's nothing else we have to say to you. There was no more, follow-ups or anything like that. That was a big challenge to me, and it really affected my family emotionally and psychologically, being with the health problems that I had.
Could you tell me what sort of psychosocial support you had, if any, after you were given your diagnosis?
The only support I had was my family. Like I said, I didn't hear back from any of the doctors that I went to. My family was there. My biggest thing was trying to stay strong for them. They suffered more than I did personally, with the emotions, because they do know my medical history.
Right. And I mean, you raise a very important point, is that, the COVID, illness, not only is one that affects you as an individual, but really affects, and turns up the lives of, family members in really, really stressful ways. Could you give us one recommendation that you would give to, the healthcare system or to doctors related to COVID and management?
Yeah, when people test positive, I mean, communicate with them, talk to them. I know it's not much treatment that they could do for it, but, all from psychological treatment, their family psychological treatment. Don't just leave them out there and say, you're positive, stay home 14 days and then go from there. Offer them some follow-up testing after the 14 days, because I was offered none of that. It was like, you'll be better in 14 days and you can go and do what you want to do. So people educate themselves and talk with their doctors and try to, stay on course with their doctors and the psychological part of it.
Thank you, Mr. Palmer. So I hear what you're saying is that there is, quarantine is tough and must be linked with constant social support, whether it's, sort of via remotely, through video screen, which can be tough in minority communities.
Yes, ma'am.
Who might not have a computer, but might be doing it on your phone for assessment. Once again, thank you so much for being with us.
Yes, ma'am.
We really appreciate you coming out from Mississippi to share your story.
Thank you.
On behalf of the Association of Black Cardiologists, thank you for joining us today for our webinar. We hope that you choose to become a member of our organization. We all need to work together to stamp out health and other disparities. Let us not sit back and admire the pandemic's disparities. Do whatever you can. If you're a COVID survivor, donate blood or plasma. We dedicate this webinar to the parents of Dr. Sherry, who gave their lives during this pandemic. We also dedicate this webinar to all persons who've lost their lives due to COVID-19. Once more, I'd like to thank our speakers, Mr. Palmer, Mr. Augusto, Dr. Sherry, Dr. Peter Chin Hong, Narissa Hayes, Kevin Alexander, and David Williams. These webinars leave me feeling at loss because there's so much that we need to do. There's so much, but we can all do things in our own little way. The question and answer session we went over, so we won't be able to take question and answers, but this is what we'll do with the questions. We have the questions that you've put forth, and we will try to incorporate these questions as best as we possibly can into our Q&A. I will say finally, please visit our website for the posting of this webinar. Our COVID-19 FAQs, which have been highly successful. We have also a community FAQ, which was pioneered by Dr. LaPrincess Brewer and Dr. Daphne Ferdinand, along with Dr. Kevin Alexander, to look at for relevant manuscripts, especially those manuscripts from our members. To make a difference from a scientific perspective in this pandemic and in other cardiovascular disease. ABC is co-sponsoring a webinar next week run by Akano will be one of the co-chairs. And your blessings. Thank you very much.